Well, the implications of the phase 2 registrational trial that was done really changed our ability to impact patients' lives and their survivals, because keeping in mind that all of the prior therapies we had access to provided palliation with limited disease control. Looking at the results of the cemiplimab trial, these patients have a very high response rate, better than 50%. But what we see, even more importantly, is that there's a plateau on the response line. So that plateau indicates that these patients are having long-term durable responses that we're hoping translate into cure for these patients.
So real-life therapy versus systemic therapy based on EMPOWER. So the EMPOWER study gave us some very good information about cemiplimab, the approved therapy for cutaneous squamous cell carcinoma. So it told us that there is a therapy that can be given by an intravenous infusion that is effective. It told us that the time to start seeing a response can be under 2 months. It also told us that we can get a overall response rate approaching 50% and a durable response rate approaching 60%. So these are things that we didn't have before. We were unable to provide this type of therapy because there was nothing approved. There were other systemic therapies approved for squamous cell carcinoma, but not for cutaneous per se, similar therapies. So, with an approved option, we certainly have more choices now, and we can offer this to our patients to at least give them another choice besides either disfiguring surgery and or radiation that may or may not cause them some morbidity down the road. So it's nice to see some of this data. Of course, we'd be looking for longer term data as more patients are exposed to the medication. Over time, hopefully we'll see some improved outcomes. As far as the adverse events go, they seem to be manageable based on the trial data that we've seen so far, so that's always good to see as well. So the EMPOWER study taught us some things about how we refer patients for systemic therapy versus real life. So in studies which are very well controlled, the subjects that are enrolled in the studies are usually of a more severe type. So more advanced cases of squamous cell carcinoma. These patients have also been exposed to radiation therapy before and maybe not done well. So the criteria are higher for a trial. So we learned in the trial that the overall response rate was approximately 50% for the patients that were enrolled in the trial. We also learned that the durable response rate was almost 60%. So, and the last thing we learned was that the time to response was pretty short at about 1.92 months or so. So what does that tell me? I think that tells me for my community-based practice that there are patients in my practice that could benefit from going on IV cemiplimab or the approved medication for cutaneous squamous cell carcinoma that may not be quite as severe as the trial subjects were. So I would consider that a patient with advanced squamous cell carcinoma that we would consider unresectable, maybe it would cause a lot of morbidity for the patient to remove that tumor. Maybe the patient would have damage to a critical structure, or they would have a large cosmetic deficit, or if, of course, they've been diagnosed with metastases of any kind, certainly this would be an option for us. So basically the bottom line is real world versus trial. Trial subjects are typically, especially in this case, more severe subjects. So we might consider it for a broader range of patients in our practice versus the subjects in the trial.
Whenever patients are enrolled in a clinical trial, the eligibility have to be more focused. When we get into the real world, then I think it depends on whether the environment that patient is seen is at a comprehensive cancer center where there's already a multidisciplinary team, and we evaluate our aggressive cancers of all types for trial eligibility all the time. In more of a community setting, my guess is that it's different than the clinical trials, whereas at our center, we were already adhering to those kind of eligibility categories of the unresectable population, the recurrent metastatic. We don't segregate them. of course, like a clinical trial expansion cohort did, but we have a multidisciplinary treatment team that assesses for eligibility along the way. Now, once a therapy becomes FDA approved and one can use it, in standard practice, then the combinations and then the more innovative ways to look at its combination with radiation or potentially with cetuximab, because both may be FDA approved, and then the oncology team can begin integrating it into conventional approved therapies, and that's where we are.
Anytime that you conduct a clinical trial, the criteria for enrollment are very stringent, again, because you need to factor out complicating factors such as autoimmune diseases, and many older patients will have an underlying autoimmune disease, whether it's CLL, whether it's rheumatoid arthritis, whether it's psoriasis. So those patients were in fact excluded because you have to in order to really tease out what's the toxicity and how well patients will do. So using these drugs in the real world, those are clearly not going to be rate limiting factors. You just need to be aware that when you treat patients who have underlying autoimmune diseases, these medicines, like the other PD-1 inhibitors, are going to exacerbate those symptoms. And you have to work as a team and work with the rheumatologist in order to either control the rash or control the joint pain. But you can easily treat these patients and manage their side effects at the same time. The long-term efficacy and safety data is really not long-term. The trial has been closed now for a year and a half, and so that's your long-term safety data. But at a year and a half, again, the responses are at 50%. We are not seeing any long-term adverse events. We do know, like all the other immunotherapies, if a patient develops an endocrinopathy, like hypothyroidism, which is the one that was most commonly seen in the cemiplimab trial, the hypothyroidism is usually permanent and needs to be treated with thyroid replacement medication for the remainder of the patient's life.